A 55-year-old female presents with complaints of fatigue, generalized bone pain, and a documented history of recurrent nephrolithiasis. Additional symptoms include increased irritability and impaired concentration. Laboratory evaluation reveals a serum calcium level of 11.2, reference range 8.5 to 10.2, a parathyroid hormone, PTH, level of 85, reference range 10-65, and vitamin D levels within normal limits. The patient has no significant medication history. This clinical scenario is consistent with primary hyperparathyroidism, a disorder characterized by excessive autonomous PTH secretion resulting in hypercalcemia. However, differentiation from secondary hyperparathyroidism is critical, as the two conditions diverge significantly in laboratory findings and underlying pathophysiology. Accurate differentiation between primary and secondary hyperparathyroidism relies on a thorough understanding of their laboratory profiles and etiologic mechanisms. Primary hyperparathyroidism. This condition arises from autonomous hypersecretion of PTH, most commonly due to a solitary parathyroid adenoma or, less frequently, parathyroid hyperplasia. Laboratory findings demonstrate elevated PTH levels in the presence of hypercalcemia. For USMLE Step 1 preparation, it is essential to understand that this dysregulation increases bone resorption, enhances renal calcium reabsorption, and augments intestinal calcium absorption via elevated 1,25 dihydroxyvitamin D production. Clinically, patients may exhibit nephrolithiasis, osteoporosis, and neuropsychiatric manifestations, as observed in the vignette. Secondary, hyperparathyroidism. This entity reflects a physiologic compensatory response to chronic hypocalcemia, often secondary to conditions such as vitamin D deficiency, chronic kidney disease, or gastrointestinal malabsorption. Laboratory evaluation reveals elevated PTH levels alongside low or normal serum calcium concentrations. For USMLE Step 2, identifying the precipitating cause, such as renal failure or inadequate vitamin D intake, is fundamental to establishing the diagnosis and directing management. In essence, primary hyperparathyroidism is defined by inappropriate PTH elevation with hypercalcemia, whereas secondary hyperparathyroidism features appropriate PTH elevation as a response to hypocalcemia. Therapeutic approaches for primary and secondary hyperparathyroidism are tailored to their distinct etiologies and clinical presentations. Primary hyperparathyroidism. The definitive treatment for symptomatic patients or those with evidence of end organ damage, e.g., nephrolithiasis, osteoporosis, is surgical parathyroidectomy. In asymptomatic individuals or those with mild disease, regular monitoring of serum calcium levels and bone mineral density is advised. When surgery is not feasible, pharmacotherapy with calcimimetics, such as cinacalcet, may be employed to suppress PTH secretion and mitigate hypercalcemia. Secondary hyperparathyroidism. Management centers on correcting the underlying cause of hypocalcemia. In cases of vitamin D deficiency, supplementation with cholecalciferol or calcitriol is indicated. For patients with chronic kidney disease, treatment includes phosphate binders to address hyperphosphatemia and calcimimetics to modulate PTH levels. Parathyroidectomy is reserved for severe refractory cases unresponsive to medical therapy. For USMLE Step 3, clinical decision-making hinges on selecting the most appropriate intervention based on the patient's laboratory profile and symptomatic presentation. Let's summarize. Primary hyperparathyroidism is characterized by elevated PTH and hypercalcemia, managed primarily with surgical intervention or conservative monitoring. Secondary hyperparathyroidism is defined by elevated PTH with low or normal calcium, treated by addressing the underlying etiology. Good luck and subscribe for more.